emergent mitral valve repairs. So, relatively low risk of complications from reusing the balloons. And if we look at the study where the balloons were not reused, they actually had a pretty similar set of complications and complication rates. The one thing that they didn't have was stroke. So they didn't have any patients who had a stroke. But they had about 2% thromboembolism, which is comparable to the other study. So, the main difference that we can find between using a reusable balloon and a new balloon is a less than 1% risk of stroke. So, in summary, 41-year-old woman, severe mitral stenosis, moderate AR, and based on the literature review, we think that PMVV is a reasonable option, and we think that it's reasonable to use a reasonable balloon. We're comfortable with the complication rates. And of course, we acknowledge that she's close to severe with her aortic regurgitation, and at some point, she is likely to need an aortic valve replacement. But we don't think she's there yet, and from the literature that we have, the vast majority of patients with NYHA class 3 symptoms do quite well after PMVV alone. So that's kind of where we are. We're going to go ahead with PMVV. What kind of comments do you guys have?
Is there mitral valve is fit for BFP? Is there any calcification in the mitral valve?
So the leaflets are thickened. There's no obvious vegetation or calcification, and there's what we think is mild regurg. Mild regurg wasn't reported on the outside echo, but we think we see some mild regurg.
They would like to have transesophageal echo for rolling out left atrial appendage.
So yeah, that's the other thing is, obviously we're going to do a TEE and CAT at the time of the procedure, and if those hemodynamics and valves don't look favorable at that time, then we would opt to transition to an open repair.
So it was really very interesting. Like I was doing the echo and I got blocked at one point. I even couldn't figure out where those values